Yeah. My slides are visible?
Yes, ma'am, it's visible, but it's not in the slideshow form.
Yeah. Can I request to stream in the normal mode? Because no, I can see the video in the side. Otherwise, I have to talk only to the slides. So if the slides are visible, can I continue?
Slide is in slideshow presentation is not there. This is your desktop is display, but PPT is not open, ma'am.
It is not opened.
No, ma'am, no, it's not opened.
One minute.
Yeah, sure, ma'am. Ma'am, if need help, then we can display from here also.
No, only thing is, no, I have made it in Office 365. So
Okay.
when I present, no, it comes with the graphics. When I
Okay.
have sent to you, the graphics were missing. Only if you have Office 365, it will come with the graphics.
Ma'am, I
Let
can
me
suggest
try.
you, it won't be an issue if you can just share your whole computer screen. Yeah.
Yeah.
Is it visible now?
Yeah.
Yes, ma'am, it's visible.
Okay. So I think if the slides are visible now, can I do it like this instead of the
Ma'am, you can
It's up
try
to me.
for the full screen. There is a button, if I can see under LV. There is a button upside.
Yeah.
Under LV. No, not on this. Just under it. Like the drop down menu under the LV, there is a left button which is like a glass of a thing. If you see under the glass signature, just a little bit upwards. Yeah, this
No,
one.
I know that. I know how to make it as a slideshow.
Try it once now.
No, when I make it as a slideshow, I will not be see any of the participants. I will be talking only to the slides.
And that's how it is.
Yeah, because no, I will not be
Here
viewing
it is.
anyone. I have to talk to the slide.
Well, ma'am, there is one thing. If you can go, there is an option where you can see the participants up in the top bar actually. But that
How
setting
to
has
do
to
that?
get
How
enabled.
to do that?
But that setting has to get enabled prior in your system. Or in case if you just go upwards, you can see view options or something. Do you see anything?
At this corner, ma'am, view option will be there.
Yeah.
At corner. So from there you can.
No, it is not there.
I think this is the best way. You can go ahead with the same also.
Yeah.
Yes, ma'am. As per your restrictions, ma'am, comfort, you can go ahead. Whatever you want, ma'am.
Okay. No. I think I managed now. I managed. Yes.
Okay,
Yes.
Okay.
Yeah.
Yes.
Yes. Now I could see few of the videos, Yes.
Okay, ma'am, sure.
No, otherwise I have to talk only to the slide. No, without any facial feedback, I have to talk. Okay, fine. Now, without much ado, let me enter into the topic. So the COVID-19 pandemic has created devastation in every facet of life globally, and recovery will take definitely many years. The first few cases of COVID-19 were reported in China in December 2019. And on March 11th, 2020, the World Health Organization declared it as a global pandemic. And the healthcare system, in particular has suffered in many ways, with mixed and conflicting messages which were appearing in social media, fluctuating patient volumes, resource uncertainty, and personal illness and death. And all healthcare workers, including nurses, faced intense challenges. The medical field is no stranger to crisis, but COVID-19 has caused in many cases a profoundly heightened environment extending not just to the professional, but to the personal lives of employees, leaders, partners, and patients. The rapid onset and intensity of this pandemic has left the society and healthcare systems in particular reeling from the effects and wondering how they could so be unprepared. And what did the pandemic has taught us? There were some key takeaways. Remote work and productivity are friends and not enemies. Because if somebody asks you, I want to work from home, as a principal, I would have not accepted. But when the pandemic came, we were able to accept if they want to work from home and connected online to complete their classes. So we started accepting remote working and productivity as our friends and not our enemies. And distance impedes communication. We also overcame that. We were able to get connected globally, and we thought distance is not an impediment to communication. And empathy is essential. We try to understand when our own colleagues were suffering from COVID, when their family members were affected with COVID, we were able to be more empathetic in understanding the situations. And people also have re-evaluated and recalibrated their leadership styles and the way of functioning. And the leadership habits which were practiced during COVID-19, first we thought that self-care is very important. Only if we are healthy, then we will be able to take care of our dependents, both in the workplace and at home, and rely on your own team. We started understanding the team members, and we have started upon them. And planning and preparation are the key. Instant planning and preparation is definitely essential to manage the pandemic, that we have learned. And communicate thoughtfully, and personal ideas matter. From each and everyone we were inviting ideas, because nobody has came across such a pandemic before. And get to know others better, use partners, peers, external experts as resources, and study the facts and be transparent, and reward your team and move forward, not backward. That was the wonderful lesson the pandemic has taught us, because every time you're getting new variants of the virus, and we are moving forward, not backward. And there is also a reality to attached with it. When will we return to the normal life? We all have adjusted to a new normal life, moving with the mask and social distancing, and adopting hybrid methods of teaching learning process and whatnot. We have to move only forward. We do not know when we will resume the normal life before. So adjusting ourselves to the new normal is also one of the leadership habit we have practiced, and we are looking forward due to this COVID-19. And there were the phase one of the pandemic. How did we manage? We managed to do the triage, and among the crisis, we continued the educational process. Teaching learning process was never given a stop. We tried to continue our activities. So how it was managed? By developing the policies and procedures that prioritize the safety of the students, faculty, staff, and the patients. And guidance statements, task force were created, and listserv was created. And suspend in-person clinical training at practicum site. We were not able to continue the clinical training at the practical areas. And this has increased the awareness about the collaboration between the academic institutions and training sites. And conversion of education and training mode of delivery from in-person to remote online instructions, telepsychology, telesupervision, all were practiced. And social responsiveness, advocacy for the differential impact of COVID on students, faculty, and staff was better understood, and that was utilized to develop the policies and procedures, keeping in mind the welfare and continuity of learning of every segment of nurses. And in phase two, what did we do? Enduring and maintaining quality and the community connectedness. So ensuring quality, we understood that the learning is going to be online, remote learning has to happen, but still how to ensure the quality. So we explored the methods of ensuring the quality. And I remember in the previous institution, when we introduced the online classes, we had observers. So observers were also monitoring and helping, because sometime no, there will be difficulty of sharing the slides, difficulty to manage the group. Sometime you need help from other faculty members. So we made observers to help each other. And also we made the quality by improving the quality by fixing polls and quiz programs in between the classes. Like that, no, several methodologies were used to improve the quality of online learning. And documenting the adjustments, creativity and flexibility in the assignments, competency exams using the technology, and supervision using the technology, all these were explored. We made the students to keep their Zoom or Google Meet on, and we asked them to write the exams. And we also tried a few of the softwares for proctoring. Of course, that were not really very helpful. But still we explored the opportunities. How can we monitor the students, especially when they are appearing for exams? And a lot of creative ideas were brought in, methodologies were brought in, how to engage them. And one such I can share, image based learning. Like, you know, all the theater instruments and all the OT techniques we are creating in the form of images. So we thought we will use image based learning. And even if the pandemic is getting over, we thought we will use all these methods, so we can orient the students before they go to the clinical area through image based learning or through video based learning, so that it will promote the curiosity in the minds of the students when they go to the clinical areas. What we have learned through images, through videos, through online classes, they will be able to appraise and compare in the physical settings. And you know, we had virtual office hours. Of course, we were missing the tea and snacks during the virtual office hours, and that was also made possible, I think, when we we attended examination online. They ordered the lunch through Swiggy and Zomato. So the snacks and refreshments and lunch was also reaching to the table. Somebody was coming and delivering. So that way, you know, none of the aspects of physical classes were compromised. Even virtually also, we were still able to engage by having all the aspects of the teaching learning process. And of course, sorry. Some of the values which we have learned was safety, compassion, serving the underserved community, and taking care of our family members. Or we got more time to spare with our family members. And we were able to follow the CDC guidelines, and we were able to still get connected with the accrediting bodies for admission process, instructions, training, and for the service delivery for telepsychology training. And we were getting connected with the licensing boards as well for self-screening surveys, attestation, testing capacity, wellness and well-being activities organized by the licensing boards and accrediting bodies. And for academic institution policy, we made sure the research is being continued. I still want to share here that many of our students data collection was made online. You know, offline data collection was not possible, so we permitted online data collection. Modifications in the research protocols were brought in, and still we helped the postgraduate students and the doctoral students to continue their research activities and complete their research studies. And continuity of the clinical training and services were made. Whenever there was possibility, we have sent them to the hospital for direct patient care experience. Whenever it was not possible, they practiced it in the lab, and simulation scenarios were created, and the clinical experience was continued in the form of simulation. And of course, the financial problems of the students were also kept in mind. Suddenly we ask them to go home. Suddenly we ask them to come back. The students are from all over India. They have to book their tickets and they have to spend on additional travel expenses. And those kind of financial commitments were also kept in mind. And we required expenses to install the interactive boards, other systems required, softwares required, and subscribing the links for conducting online classes. Like that, additional financial commitments also took place during the transitional period. So what to do now? We have seen how we reacted to the pandemic and how we explored the opportunities and how we have refined ourselves to deliver quality teaching learning experience. So what to do now? What is next? The pandemic is not going to end, because every time we are getting newer versions of the virus entering, and we are coming up across cycles of lockdowns, partial lockdowns, and we have to what to say, we have to modify the plans which we have made, the master rotation plans, clinical rotation plans, and we have to be flexible according to the situation. We were modifying the teaching plans. All those we have done. So what to do now? So we have to review the purpose, and we have to use this retool approach. That means the tool which was once helpful may not be helpful in future. So we have to adopt and adjust and invent newer tools for helping us to overcome the difficulties and still making the patient care and teaching learning process to be continued. And we have to remember the basics. We have to have open mind, invite the suggestions, listen to people, give value to everyone's idea, and we should have open heart to understand the difficulties of others. We need to be empathetic, and we should have open ears, and we have to look for opportunities to explore and make use of everybody's suggestion to improve the situation. So these were the learnings we had from the pandemic. And there are two types of leaders. One is the legacy leaders and learning leaders. Because in this session, we have to discuss about the leadership strategies which will be helping the nurses to overcome the challenges of the pandemic. So there are legacy leaders and learning leaders. Who are these legacy leaders? Legacy leaders are marked by linear thinking and working within the existing system, be it education, healthcare, or whichever setting they are working. Whereas the learning leaders, on the other hand, are constantly seeking to expand, learn, and grow from failures and look anywhere and everywhere for good ideas. So we need to have more of learning leaders during the pandemic. So we need to leverage the partnerships and collaboration in making the process a successful one during the pandemic. And these are some of the practical strategies which we can apply as the learning leaders. One is pre-mortem. We have only heard about post-mortem, that is after some incident has happened, we analyze the causes and we do the corrective and preventive action. Whereas here you need to be proactive and we need to do pre-mortem. We have to analyze the situation beforehand and we have to have after action reviews also. So we need to hold team meetings that both preemptively identify the risks and review projects after their completion, and weighing the likelihood of potential risks, making the pre-mortem particularly valuable when navigating the new territory. And after action use identify the lessons learned, best practices, and most importantly, how to mitigate any risks moving forward. This can provide value in both healthcare delivery and the management practice. And we also need to practice empowerment and communication as the strategies. Empowerment of staffs by providing them authority and context to make decisions and drive the initiatives. And additionally, create a learning environment and provide training to ensure that they can make best use of this empowerment. And communication, fully rethink how meetings are structured and how communication flows within the organization. Large information sharing meetings that cross the departments and functions are one way to achieve this positive disruption. Forums where senior leaders discuss the industry, company, and social trends in ways that enable all teams to understand their roles are also similarly proven to be powerful. And we have to have these strategies to support this learning leader approach. So the leadership development training can be organized, make time for and invest in leadership development across multiple levels for the organization. It is not only for the top level leaders, for middle level, for all the people, this learning leadership approach has to be given the training. And every workplace has diamonds in the rough, talented, motivated, and ambitious individuals who lack the exposure or experience to be as effective as they could be. So we need to polish the diamonds and make them shine so that they will be benefiting the patients and students. Providing leadership training can often yield significant returns in innovation and success throughout the institution and system. And how to improve nursing leadership during the pandemic? We need to host capacity building programs, and you must be watching the AIMS website. They have clinical grand rounds on every Tuesday and Fridays morning. It is also streamed live, and many people across the country, they attend this national grand rounds in which they discuss the issues and the strategies which we can follow, which is followed by AIMS. Similarly, every institution must think of the capacity building strategies of their employees. And teamwork and networking, we learn from each other. The strategies which is used elsewhere has to be analyzed, and we must see whether we can adopt it. It can be not only within the institution and in other institutions and in other countries as well. And I still remember when nurses were have to manage this COVID, many associations were getting connected with the associations in China, Japan, and other countries, how they overcame the challenges. So that way, COVID has promoted a lot of networking and learning from each other, irrespective of the boundaries. And community engagement. No, patients will give best feedback. Patients will give you the best strategies because they have undergone the experience personally. So we have to engage the patients and the community to give us ideas how we have to improve our systems. And of course, research has to be done to evolve the models and to test the models which will guide the future leadership during the pandemic. And infrastructural facilities, especially we came across a lot of difficulties due to this infrastructure, because 50% social distancing has to be practiced and we have only fixed classrooms. So how to manage the social distancing? Then 50% will attend offline, 50% will attend online. That way we managed. So the infrastructural facilities have to be definitely looked into. This was in the academic settings. Similarly, in clinical settings, they required area for donning and doffing. And sometimes the nurses were quarantined within the hospital. They did not go back to their families. So you have to provide accommodation within the campus for quarantining themselves. And you cannot have the patients overcrowded in the general wards. So maintaining social distance in the wards and other infrastructural requirements, what was required, also has brought in a lot of improvements. We did not have the hand sanitizers installed before entering the hospital. Now every hospital, every place where you go, you have hand sanitizers installed. So you can sanitize your hand, and never we used the hand sanitizers to this extent. And similarly, we can explain the facilities for PPE and biomedical waste management of the soiled items which is coming out of patient care of COVID patients. Like that, we can talk in detail about the infrastructural modifications and requirements which was required during the pandemic, both in the academic settings and the clinical settings. and service delivery. How to continue to deliver the service without any discontinuity. That also needs improvement. And nursing workforce. Many nurses were affected. The other day, I was talking to someone in Karnataka. They said that around 70 to 80% of the hospital staff, including nurses, are positive. And earlier they were given 2 weeks of leave, then it was reduced to 10 days, then 1 week, now 3 days. So the nursing workforce has to return after 3 days, even if they are tested to be positive. Still they continue to work because there are many patients who are flowing in and we need the manpower to take care of them. So lot of compromises, lot of adjustments, and the dedication which was required from the nursing workforce. And so these were all some of the areas where the leadership during the pandemic was improved, and the availability of the orientation or training offered by the government and NGOs, then potential of developing well-targeted continuous professional development programs. This is required. No, every time they said that third wave of COVID has come, it is going to hit the pediatric population. So we need to prepare the nurses to care for the pediatric population. In NEIGRIHMS, we were using the trauma center for the COVID patients, whereas the nurses working in trauma center are not capable of caring for the pediatric population. Like they need reorientation, because in trauma center they were caring for adult patients only, but suddenly the pediatric age group is going to get admitted. Are nurses tuned to care for the pediatric population? Then we made the pediatric emergency preparedness program and empowered the nurses in pediatric emergency skills. So continuous professional development programs have to be organized. It need to be need-based in empowering the nurses, and emphasis should be given on specific competencies like infection prevention and control measures, critical nursing care procedures, and the epidemic preparedness, and how to respond to the outbreaks and epidemics and pandemics. Furthermore, lobbying, communication, and technology use are important for continuous professional development during such crisis. And teamwork and networking is also essential. Systems awareness of the importance of teamwork, broadened partnerships, and enhanced links with organizations that support health facilities needs to be explored. And nursing leadership being closer to nurses in service areas for mentorship and support. Mentoring the experienced nurses is required. Of course, preceptoring is done for the entering nurses, but mentoring is for the experienced nurses. That has to be designed and implemented. And broadening of the experience by exchange among various health facilities, engagement of NGOs in continuous professional development activities, and the indispensable role of multidisciplinary teams in service delivery, that is on health promotion and prevention care. Here I would also like to mention that Ministry of Health and Family Welfare took the effort to prepare the modules for all healthcare professionals, including doctors to that of technicians and nurses. And for nurses also, the modules were developed. 19 modules which were not already present were developed and hosted in the iGot platform. And similarly, all for the adult care, for the pediatric care, and for the care of obstetric clients and newborns, so many modules are prepared and hosted in the iGot platform, which is free for the nurses to access. And we must encourage nurses to update their knowledge through these platforms. So government gave us a lot of support in promoting the understanding of the pandemic, and learn from each other and design our systems to meet the challenges which the pandemic has brought in. And community engagement and research is also important. So participation of the community in implementing the policy changes need to be promoted. This can enhance and sustain the community health seeking behavior during a pandemic. And participation in operational research. This is an important aspect of nursing services that requires much more focus in the future to ensure that evidence derived from nursing research is put into practice. and introduction of evidence-based practice to ensure delivering nursing services that is verified is also required. And infrastructure upscaling. As I told you that we need to upscale the infrastructure. Lack of facilities for nurses and other healthcare workers at the start of the epidemic will affect the motivation of staff in pandemic centers. So we have to provide the facilities for donning, doffing, taking adequate rest, changing rooms, and other facilities have to be looked into. And in the academic areas, for maintaining the social distance and the online teaching facilities have to be upscaled. And infrastructure limitations affects the implementation of social distancing policy and other pandemic appropriate behavior in workspaces like sanitary facilities, including the showers. They want to take bath before going home, then changing rooms for staffs at the end of their shifts. All these have to be taken care of so that they do not have the fear of transmitting the infection to their families. And service delivery, improvement in emergency response. Suddenly you get so many people entering, there is none, and we had crisis of oxygen, and now there are so many programs are designed on rational use of oxygen and how to minimize the wastage of oxygen and how to design the therapies for maximum use of oxygen in a cost effective way. All those are being done part of the emergency response. Similarly, we have to look into many aspects how the service delivery difficulties were managed so that we are able to provide emergency responses when the pandemic outbreaks. And awareness on infection prevention practices, care and program management, innovations in the time of scare, and consistency in grant approvals to ensure availability of medical, non-medical supplies and materials. Recognition of the importance of adherence to universal precautions and PPEs, recruitment of higher number of nurse leaders to improve the quality of work through mentorship. All these were some of the strategies which we can use in the future to improve the service delivery during pandemic. And nursing workforce also have to be strengthened. So the staff placement, redeployment, in redeployment, even the retired nurses were asked to come and help. Whoever are willing to come and help, even if they are not employed, was invited to help during the pandemic. And encouragement and reassurance was a big part of ensuring services were delivered accordingly. And employment of nurses not in service due to sudden surge also was sought. And recognition of importance of staff placement, deployment, motivation, encouragement, reassurance for nurses in a health risk area was required, and we need to keep this in mind when we are planning in future. And of course, making improvements in staff well-being, visibility of the importance of nursing leadership and management in the effectiveness and efficiency of service delivery has to be done. Strengthening nursing leadership and reporting of health systems data has to be done, and potential for establishing well-resourced physiological support system for nurses, that is carer of carers. This situation we have come across when the nurses got affected with COVID. Who will take care of them? No, during the first wave of COVID, I remember the nurses were affected and they were all quarantined, and each one were taking care of the other. So we have to design the strategies. Who will care for the carers? Who will care for the nurses if they have fallen sick? That has to be designed. And the difficulty in work scheduling and assigning of duties due to shortage of the staff results in psychological and physical strain among the available staff. So we have to see that these staffs who are remaining healthy are not overloaded due to the shortage. Motivation is an important component of the leadership strategy to be followed. To sustain motivation, facilities for psychological support, medical care, mentoring, and a clear policy on incentives are required, as well as a continuous professional development program that addresses the competencies in nursing leadership and critical care need to be planned. And finally, transforming nursing leadership during pandemic, we have to establish a sense of urgency, form a powerful guiding coalition, create a vision, communicate the vision, empower others to act on the vision, plan for and create short-term wins, and consolidate the improvements and produce more change and institutionalize new approaches. So these are all some of the leadership strategies we can follow during a pandemic. And transformation in healthcare shouldn't be done in the fear of the next pandemic. It should be done with longevity, sustainability, and improved patient outcomes and access in the mind. The lessons and opportunities presented by the past and current pandemics highlight the key areas of change that will not only enable a new, more collaborative model of healthcare to emerge, but better position our system to withstand similar pressures in future. So to conclude, besides the speed of needed change, the challenges have included redesigning care and staffing models on the fly, developing crash courses on critical care nursing, and completely transforming hospitals in a nanosecond compared with our usual planning models. Despite command control crisis management, we have listened with an ear to the ground like never before and allowed all the ingenuity testing of new practices and innovation possible. This takes grit and resilience. These are the experiences we want to learn from when we reset for the future. Thank you very much.
Thank you. Ma'am, thank you so much. So thank you so much for sharing such an enriched experience and, giving us enlightenment regarding the strategies of the different varieties of leadership steps. So thank you so much, ma'am, once again. So, ma'am, I wanted to request you to stay back because we are taking all the questions at the end. Till now, we have not received any queries. But even if you participants, if you are having any queries, please write down in your chat box. So we will take up at the end. And
yes. It's not only the queries, if they want to add on any of these strategies which was successful at their institutional level and personal level, that also they can put it in the chat box, which will be helpful for others to utilize in future.
Yeah, sure, ma'am. Thank you so much, ma'am. So now without much ahead, now we would like to move ahead with our second presentation. So for that, I would like to request Mamta madam. Madam is working as a associate professor cum principal in charge in College of Nursing, Bhopal. So ma'am, floor is over to you.
Good morning, everyone. Good morning to the Principal, NEIGRIHMS College of Nursing, Dr. Mary Thom, Dr. Jyoti, and the whole staff of College of Nursing. I am very thankful to giving me the opportunity to present this presentation. Please allow me to share my slides.
Yes, sure, ma'am. Ma'am, you are co-host. You can share your screen.
Yeah, just doing it.
So our madam is presenting a barrier towards implementations of effective leadership's role among nurses. And meantime, I would like to also announce like those people who are not able to join here. We are doing a live YouTube also. You can join from there also. And please register from in Google form those who are joining from YouTube. So requesting once again. Thank you. Yes, ma'am, your slide is visible.
Yeah, thank you. Shall I start?
Yes, ma'am, but ma'am, it's not in slideshow mode. So
just a minute, ma'am.
Okay.
Okay, I think my slides are visible.
Yes, ma'am. Yes, yes.
Okay, so I'm going to begin my presentation, and the topics which is assigned to me is barriers towards implementation of effective leadership roles among nurses. And as you all know, the theme of today's webinar is leadership amidst COVID-19 pandemic, rise above the challenges. So the objectives of today's session is to discuss what is effective leadership and barriers, to highlight the barriers of leadership in patient care, education, and research in context of COVID pandemic. And the last one is to augment effective leadership and its significance in pandemic. Let us try to understand what is effective leadership. The effective leader is non-judgmental, of acceptance and awareness, focus on human connection skills, a deep sense of authenticity and integrity, advocate of staff safety, quick in thinking, flexibility, structures, calm, confidence, communication, moral courage, discipline, and decision making. What is non-judgmental? Here I would like to say that what is non-judgmental? A non-judgmental attitude is when you are not having any biasness or any thought of a person who disagree with you. Means you accept the disagreement. It is the good quality of a leader to accept the disagreement. Next is focus on human connection skills. You know, this human connection skills, a good communication skills is the foundation of any leadership and is the foundation of overcoming any kind of pandemic. Good connection skills like empathy, good conversation, face-to-face conversation, and listening other, and talking to the strangers. This is a good connection skill. And what I feel, a good connection skill is your smile, taking the initiatives. Like we have various connectors in patient care, we have various IV tubing connectors, we have even connectors when we put a patient on the ventilator. So that smile is a very effective communicator or a good connecting skill when we are trying to overcome any pandemic situations. Then a part of this, a good leader should have a deep sense of authenticity and integrity. What is this authenticity? Authenticity means you are a real one. You are expressing what you are. This is the most important thing. A real leader should be without any show off. He should be real. And what is this integrity? Integrity is when you are honest to your attitude, you are honest to your beliefs. And the another very crucial, significant characteristic of a good leader is the good leader should always advocate staff safety. The good leader should be quick in thinking, a very smart, a very prompt in thinking. When everybody feels that this cannot be done, the leader should always feel, how can I do it possible? How can I found the solution of any problem? The leader should be flexible. They should be have incident command. At the same time, calm, confidence, visibility. As Lata madam said earlier in deliberated very detailed the importance of communication and the significance of right communication and effective communication. The good leader should have communication, should have courage, caring, and the most importantly, while dealing with the crisis, a good leader should be disciplined decision maker. So when I was preparing the slide last night, I thought that whom I should quote as a good leader. And quickly, my mind recalled yesterday's news heading. This lady was in the newspaper heading yesterday, which I read. And who is she? She is Usha Chaumar. She is the Padma Shri awardee for the year of 2021. And you know what is her occupation earlier? She was a manual scavenger. She used to pick up the human excreta when she was a child, and she did whole life it. But all of a sudden, she collected the courage, and when Dr. Pathak has guided her, and she became an aspiration to the society. She started collecting all these such women, and they started a social work. They empowered those women who were the manual scavenger, and she changed the millions of the life similarly as she changed her life. She is the woman, according to me, as a real leader, because a real leader is an ordinary person. She has no formal education. She has a very low social economic background, but still she has the perseverance. She has the courage and she has the determination to change the ground realities of those women who are involved in such kind of some different kind of a profession or occupation. Earlier, the people who were distancing from her because of the work which she used to do when she was a child, after announcement of Padma Shri Award, now people are very eagerly waiting for her to welcome. I think this is a good leadership. A good leader should lead alone. Apa Deepo Bhava means when you move alone and the whole world is with you and you contribute a lot in the changing of the system, this is a good leadership. Now, I thought maybe this Usha may not be appealing, Usha's story may not be appealing to most of them. Then I thought who could be the second person to whom I quote as an example of a good leader. So for the all youngsters or the people or the students who are interested in Hindi movies, for me, the second good leader is this Nirja movie. Recently, I happened to see this movie. And if you want to learn or if you want to feel what is a good leadership in the face of the crisis, I appeal to all of you. Please go through this movie. Please see this cinema, Nirja, which is based on the real scene when 359 passengers were hijacked. And this Nirja, who was a flight attendant, she saved the life of many passengers and she sacrificed her life. And how a good leader should work when there is extreme crisis, how the good leader should mitigate the crisis within the resources, whatever the qualities which we have learned about the good leadership. I think when you see or watch this movie of Nirja, you could correlate. So for me, Nirja and the Usha, two wonderful women who came in my mind when I was trying to quote what is good leadership. And of course, we had many Usha and the Nirja when the pandemic hit to our country, and though they are not in fame, they are not reported in the media, but yes, there were so many nursing leaders who were extremely talented and very powerful leaders in order to combat the COVID pandemics. So this is all about the leadership. Now the next term which I'm going to describe about the barriers, because the topic which is assigned to me is the how we combat the leadership barriers. So this barrier actually, as this picture is depicting, barriers means barricade, blockade, boundary, bottlenecks, fence, hurdle, impediment, limits, obstacles. So, like there is a day, there is a night, if there is a leader, there are barriers. Because the leaders are made to fall down this barrier and go ahead. So this is all about leadership and the barriers. Let's moving on to the core of the topic, nurses and the pandemic. So according to Jean and Groff, nurses have always played a vital role in the response of outbreak of deadly illness. The history has witnessed the Spanish influenza epidemic, which was happened in 1918 and 19. And the story of Alberta nurses, the heroic story, you can Google it or you can see it on YouTube. Like there is a blessing in the disguise. I think in the Spanish influenza, these Alberta nurses, they become very famous. Then we also faced the SARS in 2003, then Ebola in 2014. Then we had an outbreak of MERS in 2015. Then Zika virus came, and finally COVID-19. We all are aware. What is the common in all this pandemic or endemic? That the nurses who were there at the base level, at the foundation level, who were trying to manage with the resources and trying to save the lives, regardless of sacrificing their own resources and their lives. Well, I think the topic which was given to me, I thought it is a bit difficult topic when I was exploring, but yesterday night I thought that yes, I was the right person to deliver on this topic, because when the COVID phase 1 hit and 2 hit, 6 of our faculty from College of Nursing, including me, we were given additional charge. I was acting as a CNO. 2 of our associate professor, Dr. Lily and Dr. Anurag, they were acting as a nursing superintendent, and 3 of our assistant professor, Dr. Jisa, Dr. Geeta, and Dr. Raj Ratan, they were helping me as acting deputy nursing superintendent. So I think my team has faced from very close what are the barriers of combating COVID phase 1, phase 2, because we were working on the ground day and night. For 15 months, we were having that dual role in order to face the COVID situation in Madhya Pradesh and in our hospital. So when I was reading the literature and I was digging my head into the literature, I got so many ideas and clues, and finally I have decided to categorize my presentations. So the barriers which I'm going to describe is broadly categorized in 4 categories. The barriers pertaining to patient care and the nurses. Second, barriers pertaining to education and the nurses. Third one, which is very important and crucial for us, the barriers which are pertaining to research and the nurses, means because of the COVID, how this research component was got affected, and the administration. Yes, definitely because of the COVID, we face the administrative hurdles also. So I will be dealing one by one. I hope you are going to understand my experiences, my thought process, and the organization of the slides, which I have done for the ease of the understanding. So let us begin one by one. Regarding patient care, I think Dr. Lata has talked enough about the patient care, like Madam has expressed about human resource preparedness. I could recall my experiences that all of a sudden, when the COVID phase 1 hit, there was an acute shortage of the staff. There was a shortage of the staff in numbers. There was a shortage of the staff who were willing to go inside the COVID unit. Everybody wanted to save themselves and they never wanted to go inside the unit. There were so many queries, there were so many distress, there were so many dilemmas and the fear. We had the human resources, but the human resources were not at all prepared psychologically, physically, emotionally, socially. So this was the biggest hurdle we have faced when the COVID phase 1 and 2 hit to us. Apart from the human resource preparedness, another challenge which all of a sudden the world has faced in the hospital, especially in the patient care, was a physical structural preparedness. Yes, I admit, my experience also recall that we have been ordered that, okay, prepare 100-bed ICU overnight, like you are preparing a set of a big movie. There was nothing, there was only walls. Sometimes there were no walls. We created the partition, we brought the beds, we brought the ventilators, we managed equipments, everything overnight we managed, but we prepare because the physical structure was not prepared, and there was that time, there was, you can't say no, or you can't say pause, you can't say wait. The order has to be executed because we were in an action mode. So physical structure preparedness was another challenge for the nurses. The next challenge which we faced, or the other nurses who are working in the direct patient care, were faced with equipment as a supply preparedness. As I said, there were nurses only. There was no physical infrastructure. You know, like we were entered into the COVID units, bare hands. Sometimes no PPE, sometimes no needles, syringes, no injection. Only patient is there. No oxygen is there. Equipments were coming, they were floating, and we were managing the way the equipments were floating, like getting indent. Nurses were running to the store, they were indenting, we were helping each other like marathon race. We were arranging equipments. So the shortage of the equipment or inadequacy of the supply, or the juggling of the supply, was another barrier which nurses have faced. Then the next was the adequacy of the patient care. Yes, it was very important. It was a very sensitive part of the nurses who felt that yes, the demand of the situation is that the high demand of the situation, that they wanted to give a good nursing care, but part of giving their 100%, where nurses feel that they are not able to give educate patient care because of the too much workload and the emotional weight which each nurse was carrying when they were entering and going to the bedside of the COVID patient. A lot of psychological trauma was there. The nurses were managing themselves, nurses were managing COVID patient, nurses were managing their family, their 24-hour routines. So nurses, they have felt, the nursing officers who are working among us, or the leaders who are working on the ground, they have felt the adequacy of the patients. There was a question mark, there was a dilemma whether my nursing care is sufficient or insufficient. And last one was the information updating. There was a chaos. Every minute some new guidelines were coming. Every minute something was happening, how to do donning and doffing, what are the isolation policy, what are the quarantine policy, what are the investigations policies. Every time, every minute, we were floating the roster, we were changing the roster, we are chasing the people. So there was information updating on the protocols, on the management, on the duty rosters. So this was the information updating was though a very good thing, but that at the same time it was very confusing. So these are some of the barriers which the nurses who are working on the ground felt. Now, what are the need which leaders felt? Number one is being the team. Yes, it is very crucial for us also, and the literature which I have read. It for a leader, no, just a beginning. The starting problem was there, the building a team. When you face any crisis of any type of crisis, ambiguity, uncertainty, out of 10 people, 6 or 7 people may support you, but at the same time, 3 people may oppose you. So it is very important, or it is very crucial and challenging that you build a team in order to achieve a common objective. So it was a barrier for the nurse leaders. The second is limit traffic in and out of the unit. Yes, the society was very panicked. The patients were very panicked. We were not allowing the patient to get inside. So the traffic management was the very crucial for us, because we wanted to enclose the infection or spread of the infections. So this was another task which nursing leaders or senior nursing officers has to do. They were caring at the same time. They were trying to limit the crowd. Resource management, as I had expressed earlier also, resource management not only pertaining to the direct patient care, but other things also. Say, for example, in phase 1, we have quarantined our healthcare workers. For them, arranging the accommodation, for them, arranging the room, for them, arranging the disinfectant, for them, making them comfortable, addressing their psychosocial issues, counseling. Then there are so many things. The resources are required for everything. So for those things, arranging their meals, these were very multiple tasks which a nurse leader has to do in the phase COVID-1. Staffing plan. I think this is a topic which is very close to my heart, because we have invested our maximum energy during those 14 months. Duty roster, the COVID duty roster, making a duty roster for 1,000 nurses and for more than 1,000 beds, more than 350 bedded ICU, different scattered unit was a nightmare. But yes, we could manage. It is a nightmare for everyone, because the situation were very demanding every day and night. Every shift we were opening a new unit. Every shift we were calling and shuffling the nursing officer. We were trying to manage the trial. We were trying to manage the telemedicine. We were trying to manage the admission. We were trying to give the counseling. We were trying 24 hours to manage each and every corner of the hospital in order to have a good manpower, nursing manpower. So making the staffing plan was very difficult. Not only making the staffing plan, executing it, following up of it. Sometimes somebody take leave, sometimes somebody is not willing to work in that, specifically into the ICU. So those human relations, or when we floated the COVID roster, and all of a sudden we get a lot of queries. Solving those queries was a big task for us, like preparing the nursing officer, a new nursing officer, to enter into the directly ICU or into the OT. It's a lot of psychological preparation, which my team, my deputy nursing superintendent and my nursing superintendent have wonderfully done it. Because of their contributing efforts, the collective efforts, we could manage, we can counsel the staff in order to straight go to the unit and manage whatever resources they have. We have boosted up, we have stimulated their confidence, so we could manage. And just in time training, yes, I can recall now, we were getting a standing order. Ma'am, you need to prepare a training plan online right now. And we were preparing the training programs, not only for the nurses, we were started from the ground level workers, all Safai Karamchari, even driver, ambulance worker, all healthcare workers. We have done on-site training, we have done off-site training, we have done various types of training based on the ministry guidelines, based on the our institutional guideline, and we did a multiple round, because every time the guidelines were changing and every staff wanted training. Even I also wanted training. My colleagues were also wanted training, because training has given some kind of a power to go ahead. Training has given us a kind of a courage to manage those crises situation or ambiguous situations. So there was a time when we were ever ready to prepare any kind of training, and we were delivering the training every time, and the communication. As I'm repeatedly telling, that communication is a good connector, especially in the crisis situations. So these are some of the pandemic needs aroused during the leadership. So I come across with a very good study, and according to this study, the qualitative study said that there are limited information about COVID-19. There was an ambiguity of information about COVID-19, as I have stated. And if you can recall, there were so many things like when to quarantine, when to give home quarantine, the leaves, the 15 days leave or 10 days leave, and then so many information about the patient care protocols, medication protocol, oxygenation protocols, and then precautions protocol, reporting protocols. So many ambiguities of information that there. So this was a problem, limitations. Then far less information about patient diagnosis when coming to the ED, except checking patient fever. Oh, when I'm reading this sentence, I could recall our emergency department. I mean, there was no information. The patient is coming inside the ED, and everybody is rushing towards the checking of oxygen saturation and towards the addressing the chief complaint. So like we were not able to collect the history. We were not able to manage the comfort of the patient. We were addressing the priorities. We were looking for the space. We were looking the benches. We were looking the wheelchair. We were looking the empty bed. We were looking the doctors. We were looking the supporting hands. So this was the biggest barrier which we have faced when the patient entered into the hospital. Then there is an excessive and rich source of information, but most of them were rumors and unclear. I think everybody is agree with me. So many informations were there, like this much distance we have to maintain, we have to do the gargling, we have to take the steam inhalation, and so many new things were there. So like nurses got confused, and most of them were irrelevant, unclear. I think that time our inbox, our email inbox and WhatsApp group were flooded with so many things. So this was help us in a way, but it has confused us in other way also. There is a sudden outbreak and multiple mutation of the virus causes strong need for the knowledge about the novel virus. As we all are aware that there was a rapid mutation, so it caused necessity of the knowledge and upgradation. Then another important finding of this study is unpredictable task and challenging practices. New concept for patient practices is required. Every day somebody says that we need to learn donning and doffing. Somebody says that we need to do this and that, oxygenation, everything. So new concepts were coming. So nurses used to accustom those new concepts. The important thing, which I also agree, we nurses felt powerless and limited in ability to provide competent care. We were so powerless. We wanted to give 100% care, but because of those emotional turbulence and because of this vulnerability, we have seen multiple deaths through our eyes. I have seen our wonderful nursing officer and nurses who were picking the bodies and making the bed for the new patients. They were transferring the body. Like it was like how the scenario in the airport happens, no, that the one flight goes off and the other people are waiting. Similarly, I have faced that. Means when they were like my nursing officer, my teams were filled with the fear and anxiety, but at the same time they were very courageous. They felt powerlessness, but at the same time they wanted to control the situation, and they did a wonderful job. So that was another thing. Few practical guidelines for frontline nurses and adopt treatment instead of structured care plans. So like as we are groomed, we are trained, we want everything structured. But in that scenario of the COVID pandemic, everything was shaken. There was nothing structured. Whatever coming in front of you, the nurses used to manage. So this was unstructured or a disorganized care plans were a kind of a challenge for the nurses. No experience such as this pandemic situation before, as we all know that we have never faced this situation. So we were not experienced, we were not accustomed, our minds were not prepared, our hearts were not prepared, but still we were delivering the good care. Emotional and psychological stress. Yes, nurses are also human beings. They also have feelings, emotions. They are also afraid. They also feel threatened, worried, and powerlessness. I think everybody is agree with this. The height of the psychological impact which we felt as a nursing leaders when we were facing the COVID. Imagine the nurses who are giving the direct patient care every shift. They feel a height of afraidness, threatened. There was isolation from the society, makes nurses feel depressed, We were isolated from the society. We means here in Bhopal, like various owners of the land or a home, they were not allowing, see, you are working in the hospital, so you have to vacate the rented home. And then various, I got lots of requests, allot us a hostel or give us an in-campus accommodation because the landlord is making some trouble. So that kind of isolation, even myself also felt isolation in my residence. Like people were avoiding me because I belong to a hospital. I'm working in the patient care. So that kind of isolation we have faced. Stress due to workload, definitely it was a physical stress, it was a psychological stress. It was it was a variety of the stress which we nurses face because of the workload. And why I'm repeatedly emphasizing on nurses, because we were working in very close to the patients. The level of the stress which we have and the level of the stress which the top management has and the level of the stress which a fundamental employee has is different. So like we are in the contact with the patient, direct contact with the patients, the level and the variety and the type of the stress which we face, it's unbeatable. I can't express the stress which my team has faced or my nursing officer or the senior nursing officer has faced. Yes, when you are working in crisis, when you are working in inadequacy, when you are unstable, it's very obvious and natural that we should manifest job burnout. Here also we have manifested the job burnout. I think through worldwide we have expressed the job burnout. So it was an absolutely normal feeling which we have acknowledged and everybody has acknowledged. As a leader, we should know how to address this job and burnout and how to manage this job burnout. And then fear of getting infected while participants were caring for the patient. It was like everybody was, I can recall when a nursing officer coming out from the 15 days of the COVID duty, and we had the protocol to get it RT-PCR done. So they were checking their result, and if they found negative, the joy and the expression I could see on the fear, as if a student is checking the result and he found that he is got the marks and are meritorious. So that coming out, like those days, if your RT-PCR is negative, it was like you are on a cloud nine, because you felt that, oh my god, this shift or this cycle I have saved. So this was another kind of thing. Then there was a insufficient supply, hospital healthcare system unprepared for COVID-19 patients, lack of protective facilities such as isolation units, as I have stressed earlier also, the PPE issues were there, and the shortage of staff who care for the infected patients. So insufficient support was also there. So this was all about the direct patient care. And I have deliberately discussed my experiences and I have touched only the core concept, which I felt, which I get the patient care related. Coming to the education, yes, the I was projecting the inside of the unit of the COVID-19, but there were so many things were happening outside from the hospital, especially related to the education field. So in amid panic and crisis, it is challenging to continue planning for an uncertain future. However, universities and educators have a social obligation to think long term. As Mrs. Stacey rightly quoted out, that the people who are working inside the units, their world was different. But what about the educators? What about the faculties? Or what about the students who were outside, means the campus? For them, for the authorities, it was very important that they must run the show. They cannot close the universities. They cannot close the college. Even students also exposed to COVID-19 while in a clinical settings. There is not only their health, but that of their family also. Now I'm recalling when the COVID phase 1 hit, and all of a sudden our director sir has issued a notification and student has to vacate the hostel. There was a chaos. There was a chaos. People were running here and there. Students were booking the flights, and they were very happy to leave the hostel. So this was the chaos which actually made, nobody has thought what would happen in future, what would happen in their course. Everybody wanted to reach home safely. Students expressed concern about what an interruption in their nursing education would mean for their future careers as a registered nurse. But once they reached to their home, they started giving us signals. They started worrying that, ma'am, please continue our course through online, and what will happen, especially those final year passing students. There may come a time when the needs of the public outweigh the need of the student, but slowly students realize, okay, this is a national crisis. Few of our students also volunteer to participate in the patient care. So even with the fear and the anxiety, there are lessening hope. Students' main concern have been the health of the patient and the communities. As I told, that they were contributing to us. We have engaged our students to socialize and to participate in different activities. Even we train our student also. In discussion forums, I'm quoting this study. In discussion forums, students have shared insightfulness, articulate and honest thought on the impact of the pandemic workload. For the student to enter academic program in the future, they will begin their education aware of risk and challenges that no matter cohort could have ever imagined. I think the students who have studied during the COVID through online, given examination through online, learn various skills through online, I think they are the fortunate enough, because I think they are the only batch who has experienced this innovative teaching and learning. So yes, they were special because they also supported us, and they also supported us to combat the COVID-19. So even before the pandemic, the preparation of new nurses was identified as a significant concern. Huston and colleagues described that academic practice gap as an ever-widening distance between what is taught in academic settings and the ability to actually use that knowledge upon graduation. I'm telling you that we were able to compensate in-person training or in-person education through online mode. But yes, these things are not comparable. The in-person training and the online training is not comparable. There was a gap. I think that huge gap we as a faculty felt, and I think those students who have given examination through online also felt. So there is a gap between this thing. And then another very important finding, which was given by BU in 2005, over time, only 23 to 35% of the new graduates can typically demonstrate entry-level competencies required for the practice. This is a drawback which is projected here through online. So the competencies which were projected were very less. The COVID-19 has brought nursing school to a crossroad, that is either consider the situation as temporary or a new normal. Still, we are thinking. I mean, we cannot plan ahead. I mean, every time we say that this academic plan is conditional, academic plan as per the policy of the COVID-19. So like we have mentally prepared and we have planned our academic session according to the situation of the pandemic in our country. So the challenges before us is to decide which path to move forward during and after the pandemic. Still, we think, okay, this batch is going to pass out in July. Maybe we will do it in a traditional board, the examination, everything, but we are prepared. Like for us, the first batch is also got delayed because of the COVID. So finally, the pandemic has highlighted concern about resource allocation for the students. Yes, the resource allocation for the students, like we have restructured our teaching learning style based on the online thing. So shifting to a fully online curriculum requires that all students have equal access to computers, Wi-Fi, space to learn, an environment that allows for focus in the safety. It also requires the student have sufficient competency to learn using the now mandated technology. So as we have discussed in the last session, COVID has taught us to be very techno-friendly. Our efficiency to use online tools have increased. So this was an advantage. Though there were so many disadvantages, but this was the advantage in the education side. Coming to the research, this section I found very interesting. Yes, the pandemic has questioned our patient care, has questioned our education delivery. At the same time, it has impacted on our research skill also. So let us try to understand what were the barriers, or what are the barriers which are impeding the researchability of the nursing leaders. So the pandemic has highlighted the crucial role of nurse in healthcare services. Nurses work on the front line of the healthcare system, provide infection control, education, and help reduce the spread of incorrect information about the pandemics. Why we are important in the research? Because we, as I am repeatedly telling, that we are the ground level workers. We advocate right thing and we do not advocate wrong things. That's why our contribution in research is very important. Though in order to be effective, nursing leaders must work together in a collaborative manner, following the recommendation of regulatory bodies and national and international. Like in contribution to the research, we should work at the national level as well as international levels, and we should follow the regulatory regulations. Clinical research nurses have greatly contributed to the delivery of COVID-19 research, yet the number of COVID-19 nursing-led research papers appears to be limited. Please mind it, limited, with even fewer nurses-led research projected fund. Yes, this slide is important and the sentence is important. Like I am telling that we were very rich and we were contributing from us. So many data were collected, but nurse-led researchers, specifically in context for the COVID, were very limited. So the absence of nurse research COVID-19 can be explained by why? Because of the chronic underlying factors and the feature of the pandemic response. We were busy in our own this thing. We were not focusing on the research. We were busy on our duties. Disruption of educational pipelines caused by COVID-19. with limitation on learning environment due to the pandemic mitigation measures such as lockdowns or social distancing. Yes, we had like in our institution also, in our nursing college also, we had get approval of very good important research project. But what happened when it comes to data collection, student were not here, the patients were not here, so we need to modify our data collection tool. We did data collection or research grossly based on online tools or through interviews, etc. So this was the absence of nurse leader research. The acute shortage of nurse and nursing faculty would limit opportunity to expand training, education, research capacity due to few doctoral educated nurses. As the everything was on pause, everything was impending, so the doctoral program or effective nurses, we faced lots of shortage. Then investment in clinical academic leadership for nurses has been out of step with medical professionals. Yes, the leadership program and the academic programs were also shut down because we channelize our energy to manage the patient care. Redeployment of many clinical academic and research nurses enforced by the COVID-19 response means the research expertise in nursing was depleted at a crucial time. As I told you that we were working very focusedly on the patient care. That's why this clinical academic and nurses where the expertise were deprived. Travel restrictions, cancellation of conferences further limit prospects for the internalization, global collaboration, and mentorship. Still, there are so many travel restrictions. We could not. I think it's been long time when we have not participated or organized a very big conference or workshop like we used to do before the pre-COVID era. So these are certain restrictions. There were restrictions of gathering, academic program. So these all contributed us to limit our research inclination. The lack of COVID-19 nursing research outputs may also be reflect existing weakness in the integration of nursing research in the practice. There was a weakness in the integration of the finding of the research. Local, national, and international structures do not enable prompt mobilization of the nursing focused research team because of the restrictions. We were confined to our own shell. An unconscious tendency to default to a command and control model of nursing leadership as a witness during the COVID-19 pandemic. We were trying to control. We were trying to control the situation because we were very apprehensive. I mean, we were very close. That's why means we wanted to command and control the situations. So that's why maybe the nursing research could be cornered. Okay, so this was all about the nursing research. Let us talk about the administration. What are the barriers faced by the nursing leaders in pertaining to the arena of the administrations? There are so many barriers which I could not jot it down on a single slide. Maybe you could correlate, or the leaders or the eminent listeners who are listening. I mean, it was a nightmare. Why it was a nightmare? Because nurses as a victim of organization prejudices. I don't feel any. I don't have any odd feelings to express very truly. There was a prejudices intra-professional. There was a prejudices or biasness extra-professional, and there was an inequality in regulations. I think the media reports were flooded. The kind of accommodation which were arranged for the nurses and kind of accommodations or the services which were arranged for other healthcare professionals. Sometimes there was a fight, or there was a fight or conflict between the profession, between the nursing officers or between the nursing officers and with us. So like it was an organizational prejudices which yes, everybody has felt. Lack of authority, empowerment, and the influence. Yes, even in ordinary situations, many times the nurse leaders feel there is a lack of authority or a conditional authority. So in panic situation also it was expressed that nursing administrator felt lack of authority, lack of empowerment and influence. There was no justice and the fairness. Most of the time, though it was applicable to all the healthcare workers, every segment, every category of healthcare workers face some kind of injustice and fairness. But yes, because I belong to the nursing fraternity, I can advocate that administratively, sometimes in certain issues, there was no justice, no fair treatment with nurses. Pedzer et al. Also reported there was a limited organizational opportunity for nurses. There was another administrative hurdles was lack of access to working at the strategic level. We were getting the orders. We means we nurses later were getting the orders, but at the strategic level, our visibility was little less. Our visibility become more when the action plan gets stuck and they want immediate remedy. They want immediate sort out the plan. So that time we, the nurses become, nursing leaders become very visible. Means when the things go wrong, that time people shout, call that nursing officer or call that nursing leaders. So this is another administrative hurdle. Then inflexible organizations. Yes, I said that in a COVID situation, we need flexibility, we need openness, but there are certain organizations, certain units where this flexibility was zero. So that time, administrator is helpless. Nurses not being seen as a revenue generators compared to the physicians, and the absence of nurses' visibility in policy making. Yes, it's a bitter truth, but truth is truth. Our visibility in policy making was less. We were just shown that this is the policy we have to do. Nobody cared that what are our voices, what are our concerns. The next is a lack of formal leadership training. As I told you that nobody had previous experience to deal with the COVID pandemic. We were not having, we means the nursing leaders were not having any formal leadership training, especially in context of the COVID, and nurses feeling devalued by the system. Yes, it is reality, but it is an administrative barrier which we as a nursing fraternity, nursing leaders or nursing officer felt many times we feel devalued. So, in a nutshell, the barriers which I have described are quickly revised. I have dealt with the barrier of the patient care, education, research, and the administration. To conclude, nursing leader is a very complex concept. Nurse leaders serve at different levels within healthcare organization and a junction in various types of leadership roles. Like we cannot fit into a particular frame. The situation demands we rose, we move up, we come into the action. I can recall that we, faculty of nursing college, during phase one and the phase two, sometime we were given the responsibility of the managing the hostel, more than more than 2,000, I guess. We were managing the accommodation, we were managing the food distribution, we were managing the hospital infection control policy. I mean, wherever there was need, we were put and we did 100%, and we tried to increase our visibility. So I guess we did our best because we were working in a team. So some of these roles may be a clinical nurse leader, executive nurse leader, mid manager level leaders, research leader, academic leaders, and even informal leaders within the organization. I think we have played all this role. Me, Dr. Lily, Dr. Anurag, Dr. Jisha, Dr. Geeta, Dr. Raj Ratan. I think regardless of the shifts, we were ever changing our roles. Sometimes we were working as a nursing officer, sometimes we were working as a leader, sometimes we were involved ourselves in the research. Like, I mean, I don't know like how quickly we have changed our role and we try to manage. Then nurses are even serving on healthcare boards and as a chief officer executive for the hospital. Yes, various nurses were part of the policy making. Like I was a part of a COVID task force as an acting chief nursing officer. So this was a good opportunity for me to learn and to manifest, to learn the leadership and to manifest and to contributing the voices of nurses. Nurses enter into leadership role for many different reasons. The evidences is clear that nurses leaders can make an impact. Yes, I will read it again. Nurses leader can do and make an impact. I think this is a message, a takeaway message, that regardless of the adverse situation, circumstances, we have the capacity to make an impact, and we should take a lead. Effective nurse leadership has been demonstrated to have a positive effect on the patient safety, the development of a safety climate, lower the patient mortality, patient satisfaction, and the equality of the patient care. As I told you, our visibility should be prioritized in the direct patient care, so we can do the welfare and the benefit of the patient. And it is based on the leadership or the ambience and environment which we are making as a leader to combat the COVID-19. Lessons learned from the previous pandemic indicate that a clear communication and strong visible leadership can mitigate the impact stressful event may have on our nurses. I urge to all of you, if you can recall few words from my presentation, then you can recall this connection. And you can recall that smile is a beautiful connector. Like we have an IV connector when we give IV fluids. We have a connector in the ventilator to save the life. Similarly, for leaders or for the person who work for the patient care, they have a connector. And the connector, primarily your smile, your understanding, your empathy, means how closely you accept the disagreement from other parties or from other person. So that connector is important to meet that common goal. And a lack of clear leadership, regulatory protocols, and time of crisis can lead to an increase of psychological distress for nurses. So, like, we should accept it that we need to motivate, but at the same time, as a leader, we need to acknowledge and address the psychological distress which is faced by the nurses and faced by the leaders also. Leadership through a crisis is essential for the protective effect of nurses' emotional well-being. As I told you, that staff safety is very important. So at the same time, we should also give due acknowledgement and due space, and we should address the emotional well-being of the nurses. Clear communication and strong visible leadership are elements associated with mitigation the impact of high stress event and given a healthcare staff. It is likely that the daily stress of balancing competing need to ensure the effective delivery of care is exhibited in rapidly evolving situation. I mean, it was a rapid transition. Sometimes people, staff is getting frustrated, and later on when they fight or when they exchange the heated argument, they understand that they behaved badly or they should not behave in a manner. So that was a rapid transition of the emotions were going on at all levels of nursing professionals. The pandemic has greatly affected the leadership qualities of nursing professionals, but they can be overcome by a good communication, proper delegation of the work among nurses and the nursing students. So again and again, I am repeatedly telling that good communication, proper delegation, and nursing among the nursing and nursing student is the key for the good leadership and management of pandemic from nursing point of view. So the last slide, this is the framework which I found at the last minute when I was finalizing my slide. This is a framework of nursing care, which is depicting the ABC, the autonomy, the belonging, and the contribution. The autonomy is the need to have a control over one's work life and to be able to act consistently with one's values. The belonging means the need to be connected. Again, the connection has come. And as I have advocated, connection is a good qualities of leader. So connection, cared for by and caring for colleagues and to feel valued, respected and supported is very important. And the last one is the contribution, the need to experience effectiveness in work and deliver valued outcome. So always remember this framework, the ABC, the S stand for autonomy, B stand for belonging and C stand for the contribution. So at last, I would like to acknowledge and gratitude to the all brave and encourageous healthcare workers, especially nurses who contributed to combat COVID-19 pandemic. My sincere gratitude, and I think we all are agree that their immense contribution has created the history. And I would like to acknowledge and express my heartfelt gratitude to the academic fraternity who captured and generated evidence-based resources on COVID and nursing. Because of their timely effort, we are exchanging our ideas and sharing our slide, and we are doing the brainstorming and introspecting. Yes, now I would like to thank my wonderful colleagues of AIMS Bhopal College of Nursing who have helped me to prepare the slide, who will help me or my organization to combat the COVID-19, and my PG students, my MSc nursing students who have also helped me while preparing the slides, while delivering the slides. So my very heartfelt and very a very deep gratitude to my own team, my students and everyone, because their contributions manifest in my presentation or my performance. Without them, I'm nothing. And the entire family of NEIGRIHMS College of Nursing. Yes, if they had not invited me, they have not recalled me, I may not be able to interact with more than 1,000 people. So I am very humbled and I am very thankful to the entire fraternity, the director, the principal, and the staff and the students and everybody of College of Nursing of NEIGRIHMS, giving me the opportunity to present my thoughts based on my experiences. And the last but not the least, the enthusiastic learners of today's webinar. Why I have put purposefully this enthusiastic learner, because webinar, like nowadays, like people have saturated with the webinars, but I could see the flow of the conversation, or the people are messaging, or in the chatting box people are putting their thoughts, and in initiation they have shared their experiences. So a big thumbs up to the enthusiastic learner, because you are listening, that's why I'm speaking, and my motivation is like I'm polarized because the learners are very enthusiastic. So yeah, thank you so much everyone who have listened my conversations, my slides, my PPT. It was wonderful preparing the slides. It was a very immensely learning experience for me to engage in 1 hour of this very important topic. So thank you so much. The last slide of my presentation discussion. According to the Joseph, he said the aim of argument or of discussion should not be victory but progress. So I appeal to everyone, let us start our discussion so we can progress, we can prepare ourselves, we can improve our knowledge, our skill about the leadership, especially in the pandemics. So this is all about my presentation. Thank you so much for your contribution, and thank you so much for everything. It was a delighted 1 hour for me. Thank you.
Thank you so much, Mamta ma'am. Thank you so much for presenting such a passionate sessions. Even I think it didn't felt like we have spent like an hour, because it was so interesting, and you were presenting with such a vast experience you are sharing with us. So it was a wonderful session, ma'am. So thank you so much. And as you said, like, because of COVID, one thing it has taught us like it has made us technology free. Like, because of that one only, today we are able to like 1,000 people are here over the Zoom, and also in live YouTube also approx 250 to 25 people are joining continuously. So because of this technology, today we are able to get the chance to hear such a vast experience from both the speaker. So thank you so much. And yes, here I just wanted to highlight one point which ma'am have correctly said about the research. Because being a nurse is like, it's a frankly saying, like, as per my experience also, we used to do the research only during our studies time. Like we did during our graduation times, or during our master's time. That time only we used to do the research. Apart from that, because recently also me and our this things nurses staff from globals in our organizations, we are discussing about the few of the common common topic or common problems that nurses are facing. And in that meeting, we have discussed about this research also. And what we found out like, none of us, I'm not saying all of us, but might be few people are doing research. But apart from our studies, those who are working in a clinical, so those who are working in a different area in like organizations like me, and in some other area, we are not doing that much research also, as per my experience. So here today, so many people are joining together, and might be so young nurses or our future generations are here with us. So I just wanted to highlight, or I just wanted to say, if you got a chance, or if you get any kind of support, you just do a research, come forward. If you need help, you can approach to your supervisor or your colleague, or you can approach anyone as per your convenience. But come forward, do some research, because we are working in a medical field, and every time our these things, our technology, or every time our procedures, our way of doing things, methods, every time it's keep on changing. So if we keep us update, then I think it will be a great these things relief, because I think in the research is the area where might be we are lagging behind. So thanks to Mamta ma'am for presenting the sessions in every aspect, in admin, educations, research, in covering all the topic, and with such a vast experience. So thank you so much. So now we would like to go ahead with a discussion session, and I see only 2 questions are here. So one is asked by Radhika. Like Radhika has asked, 1 minute, let me. So do like she have asked, like during the pandemic, we have overburdened and increased the nurses patient ratio manyfold, and this has caused an increase in physical, mental stress of the nurses altogether, as well as it has affected the quality of the patient's care. So her question is like, how can we overcome this challenge while maintaining the quality in a patient's care? Ma'am, these questions has been asked by Radhika. So Lata ma'am, Mamta ma'am, anyone you wanted to answer these questions? Ma'am, yes.
May I request Lata madam, if madam is available, or else if she permits, shall I answer?
Yeah, Mamata, you can go ahead answering because I
Thank you,
listened
ma'am.
only half the question.
Yeah,
Yes.
thank you, ma'am.
Yeah.
Yes, the question is very wonderful, and I could sense out that it is a core question which a nursing officer is supposed to ask. Yes, we were facing the shortage of the nurses. The solution of this problem is we should forecast the manpower planning, because earlier we were not having an experience, but now we have experience. So we should forecast the planning. We should plan ahead whatever we have learned in nursing management. So in order to maintain the ratio, and at the same time we should have some recruitment policy, the induction policy, and similarly we should have a training and the deployment policy also. So I think if we have we address this all multiple recruitment, retention, and the preparation of the nurses to post them into the critical care areas of the COVID facilities, I think we can overcome these situations, the shortage of the nurses or the burnout. I feel this is the answer of this question.
Yeah. Yes, Mamata. I also recollect when there was crisis, when there were overflowing patients in the hospitals, we also extended support from College of Nursing. The third year, final year students, post basic students, and the MSc students. They really helped to manage the crisis. So that way, we are also thankful to students. I think in another profession, the students will be supporting the manpower requirement of an organization, whereas in nursing, the students were really helping during the crisis. So that shows the strength of nursing to be very resilient and manage any kind of crisis, which is let it be pandemic or whatever huge crisis we come across, silently we manage. But only my concern is, uh, all these becomes no untold stories. We are very poor in documenting. We have to document all our experience. It should become part of the history, because we lack in documentation. So that one area we need to strengthen, so that we will learn lessons for the future.
Thank you so much, ma'am. I think Radhika, you got your answers. Thank you so much. So, ma'am, we have another questions also, like pandemic have hit globally. So one question is asked by Baisuklang. So she is asking, like, does the stress occur only in the COVID victims, or it can occur in other patients too? So this was her questions. May I repeat the questions, ma'am?
Yeah, once again, please. Yeah.
Okay. So she has asked, does the stress occur only those COVID victims and frontline, or other patients also?
Yeah. I think stress comes, COVID patients and non-COVID patients also. Because, when COVID has hit the hospitals, the routine care was stopped. Somebody who required a surgery, it was postponed. And somebody who require other treatments, especially the aerosol generating procedures like dental procedures, those are all the procedures which were halted, and the patients would have definitely suffered. And my specialty is OBG. Imagine the pregnant clients, they were not able to come to the hospital. So how many of them had access to virtual teleconsulting? Even today we find it very difficult to log in and take appointment for teleconsulting. So teleconsulting also was a stress for other patients. And as nurses, we also have not explored the opportunities to go for telenursing, because you require that bandwidth and broadcasting facilities. Only few institutions were able to support the telenursing activities. So I think the stress for non-COVID clients was also not understood properly by us, or they were making their own adjustments. But we know how difficult it was for the childbearing women, lactating women, to come for immunization of their newborn on time. And the people suffering from non-communicable diseases, especially oncology clients, their chemotherapy, radiotherapy, everything was getting delayed. So naturally, we have to address the stress of both COVID patients and non-COVID patients. That was one of the area which we ignore. When the pandemic comes, our entire concentration is on pandemic. So how it affects the routine care of other clients also have to be kept in mind. Yeah, very good comment.
Thank you so much, ma'am.
And related to the first question, how to maintain the quality, there is a session in I wrote that presentation, key performance indicators during COVID. What are all the performance indicators? So if we adhere to improving the quality using the key performance indicators, I think the quality can be ensured. I have included many quality indicators like structural indicators, process indicators, outcome indicators, including adherence to PPE, compliance to PPE wearing, so many other indicators I have elaborated in that. So those who are interested, you can visit the iGot portal and you can go through the slides. And Indian Nursing Council is also giving credit hours. When you attend that iGot presentations, you will get, I think, 0.5 credit hour for each of the presentation. There are several modules in iGot platform, so you will get the credit hours also. That is one way of motivating nurses to get themselves updated with the latest trends.
Thank you so much, ma'am. We have still 20 minutes left. So any our participants, if they wanted to share their experience, you are most welcome. So Harsh, if you are there, can you please give a chance to the participants so that they can unmute themselves? Or those people who want to share your experience, you can raise your hand, and you can also, those people who are raising your hand, we will give you the opportunity to unmute yourself, and you can add your experience, because we have still 20 minutes left. And also I have not seen any more questions out here in chat box. So any of our participants, you want to share your experience? You can write in your chat box also, so that we. I think we'll. So, no participants. Those who want to speak, please write in your chat box. Okay, I have seen one more question. So one more question is asked by Julie King. Like she said, after seeing overburden and shortage of staff during this pandemic, so what should our nursing leader do to overcome this? Madam Lata or Madam Mamta ma'am, you want to answer this one? Yes.
I request Ma'am Lata if she can share her expertise on this, how to address burnout.
I think shortage of nurses, not only during the pandemic, it is faced in day-to-day life also, and it is faced in all the countries, not only in India. So what are all the measures, especially during the pandemic, of course, extra working hours were given to the nurses. But how long we can give extra working hours? How many days we can give extra working hours? It will result in burnout. So we have to look for additional strategies. One of the strategy which I discussed was you can also call in for the volunteering nurses, those who are retired, and those who want to help beyond their duty hours. And I remember some of the overseas nurses also, when they were in India during vacation, they volunteered to help, and some hospitals, they underwent strike also during COVID. That is not the ideal time to go for strike, adding to the burden. And immediately the management was looking for contract nurses, and they appointed 400 300 contract nurses. So probably we have to have ad hoc nurses being recruited to manage the crisis. And India was helping other countries. I remember when Kuwait and other countries were requiring nurses, when in my previous organization, 300, 400 nurses from here, they were sent to the other countries to help for 3 months, 6 months, and they returned. That time India was not very badly hit. And when this Middle East virus was there, no, in Saudi, that time also nurses were sent from India to help Saudi to overcome that SARS infection. So like that, we need to mobilize the nurses wherever they are available. It can be cross country and inter country helping, inter institutional helping, interdepartmental helping. Some department might be having light workload, so you must have a floating policy where to utilize the nurses from other departments and from other institutions, from neighboring institutions. All those help should be taken. There are several ways we can think of managing this shortage of staffing. Of course, in the government sector, whichever unfilled sanctioned posts should be filled now. There are many sanctioned posts which are not filled, especially in the primary health setting. There are so many vacancies. So I think we have to be proactive in filling the sanctioned post. So those are all some of the strategies which comes immediately to my mind. And of course, this cross-country helping was a new thing I learned during the pandemic. Nurses flying from here to Arabian countries to help for 3 months, 6 months, and they return back. That is really good, so that way, I think we learned to help each other during the pandemic. So the boundaries were broken to help each other.
Thank you so much, ma'am. I think we have not seen any more questions out here, and then I have not seen any requests. The participants wanted to share their experience, so I think we will move ahead with our agenda. So now I would like to request Bada Sukshisha for a vote of thanks. She's from College of Nursing, and she is a student in
Jyoti, if time permits, you can ask your own faculty members who are with you to share their experience. You have so many people behind you attending the session. Any of them want to share their experience?
Yeah.
Or your own institutional experience also you can share.
Can call anyone. Hello? Whatever you experience. Ma'am, you want to speak? I don't have any experience. What else?
Fine, Jyoti. If none of them are willing, you can proceed with your agenda.
Thank you.
A very good afternoon once again to one and all. So on behalf of the organizing committee, I, Bada Sukshisha Nongri, from College of Nursing NEIGRIHMS. Firstly, I would like to express my gratitude to the Almighty God. Thank you, Lord, for guiding us throughout our journey in making this webinar a successful one. And I would also like to extend my gratitude and honor to our Honorable Chief Patron, Professor Dr. Nalin Mehta, Director of NEIGRIHMS, who permitted us to organize this webinar with his best wishes. Thank you, sir, for inspiring and encouraging us for this webinar. A special thank you goes to our zestful and most enthusiastic principal, Madam C.E. Murthong, for granting us the permission and providing immense support to make the webinar a successful one. I would also like to extend my heartfelt gratitude and thanks to Madam Jodibala Haubijam, the organizing secretary for our regional level webinar, for her constant guidance and support to make this webinar a successful one. I would like to also congratulate and give my immense gratitude to both of our renowned speakers, Madam Dr. Latha Venkatesan, Professor cum Principal, College of Nursing, AIIMS, New Delhi, and Madam Mamta Verma, Principal in Charge, AIIMS, College of Nursing, AIIMS, Bhopal, for the day, because in spite of in such a very short notice, they agreed joyously for being the speakers for our session. And with the inspiring words, it made us to reflect back to our duties and our responsibilities as nurses, despite the various barriers and the challenges that we encounter day by day. So I think that everyone would agree if I say that they were like our mentors, our guides, and your pathway as leaders for today made it a very a grand success for our webinar. So thank you, dear speakers. I would also like to extend my sincere thanks to Madam Nanuka Thapa and her entire team of the USAID-funded GHPIEGO RISE Shillong for collaborating with our College of Nursing NEIGRIHMS and giving us the platform to make this webinar happen in such a very short span of time. Thank you so much, ma'am, for moderating the program. I would also like to thank the RRC Northeast Telemedicine NEIGRIHMS Shillong for the live YouTube streaming for today's webinar. My sincere thanks also goes to Mrs. B. Thaba, Registrar of Meghalaya Nursing Council, for the approval as well as for awarding credit hours, to all the nursing delegates and the organizers of the regional level webinar on leadership amidst COVID-19 pandemic, Rise Above the Challenges. I must thank the organizing team for working so hard to make this webinar a successful one. And last but not the least, I sincerely thank all the participants for their active participation. Your presence has lifted up this webinar. We hope that through this webinar, we will be better nurses, starting from now, showcasing that what we really are and what we can really do through our best deeds for a better tomorrow. Once again, thank you, everyone. We now move to the end of today's webinar. Thank you. Over to Ma'am Nanuka.
Lata ma'am, Mamta ma'am, if time permits, one question has been asked by Rosabel. Hello, Lata ma'am and Mamta ma'am, are you there?
Yeah. Please continue, Jyoti.
Okay, ma'am, one question have been asked, like Rosabel is experience with, says experience with the people behavior when it comes to COVID, and some of the patients, they become very much aggressive and non-believers of COVID-19, and she's experienced lots and lots of difficulties working as a nurse. So she is asking some suggestions in this regard.
Yeah, Mamata, you can answer.
Yes, ma'am. Yes. The first point which I would like to address here is that we need to have acceptance. The fear, anxiety, or the response of the patient is absolutely normal. So we need to have acceptance, because we are trained professional. We know that in conflict or crisis, the first response is denial or aggression. So as an expert nurse, we need to acknowledge it, and we need to have a good ear to listen the concern of the patient, understand from his perspective, and then devise the mechanism how we can address it. We can give the time to patient to express the real concern, and accordingly, by following the good patient-nurse relationship steps, we can resolve this problem. I think my answer addressed the query of the listener.
I think, hope, Rosabel, you got your answers. Yes. I think yes, ma'am. I think there is no more queries, ma'am. I think we will end the sessions here. Thank you so much, Mamta ma'am. Thank you so much, Lata ma'am, for sharing experience, giving your valuable time with us, and also sharing such a vast experience with us. Thank you so much. And thank
And
you.
congratulations, Jyoti. I think less than a week you were able to host the webinar and there were no technical glitches. And the number of participants who have enrolled shows the confidence they have on NEIGRIHMS. So congratulations to all of you for hosting such a need of the hour webinar, I should say. Nobody
Yes.
has thought how to take lessons from the past and project it for the future. So that is wonderful theme which you have selected. So congratulations to all of you.
Thank you, ma'am.
Thank you so much, ma'am.
so
Thank
much.
you so much.
Thank you, Lata
Thank you
ma'am.
all the participants. And for kind information, all the participants, I have already given a certificate for the ICU, maternal, hospital acquired infections. So only the pediatric certificate is pending. So please check your mail. And if you have any problem, please reach out to me. Thank you once again. Thank you all. And thank you all the telecommunications team also for supporting us. And thank you all the team members. Thank you. Harsh, I think you can end the session.
Thank you, Nanuka. I'll do the needful. Thank you very much for your time.
Thank you, Harsh, for supporting us.